So we're going to open into question time. We do have quite a lot of time for questions and discussion, so I encourage you to become engaged in this. We're going to follow the standard format. There is a roving microphone. This session is being recorded, so we're going to ask that you don't speak until you have the microphone in your hand, and then introduce yourself and direct your question to whichever individual you'd like. I'm going to start, Roger, with my question about defining innovation. I'm not trying to be pedantic or facetious, but those of us who work in health policy actually have a little bit of innovation fatigue, and that is because anyone who's trying to do anything puts the word innovative before it, thinking that that's the only way they're going to get the ear of a minister or a Secretary of Health. So do you have criteria against which you judge something as being innovative, and is it important?
I don't think it's important to put a definition around it. If I had to be pushed, I would say it's creativity that solves a problem and adds value. But I think people get really hung up on the idea of putting definitions around innovation. It's easy to spot when you see it.
Okay. And if I'll just continue then, it links onto your points, Mary, about technology and the rampant rise of technology in healthcare. And that's case in point, because we certainly hear a lot in the health technology space about there being innovation, whereas in fact we know that we're on a drastically declining law of diminishing marginal returns, and that is that we've achieved much of the gain that we're going to achieve. Many of the drugs that are coming through are Me Too drugs. There's actually not a lot of innovation in them, in the sense that they're not really improving health outcomes, and yet we're paying more and more for them. So there are big question marks over what does define innovation in the health technology space particularly.
I think the next big area, and that's this designing, as I say, the system of the 21st century, is that huge process we've been through in the second half of the 20th century, as you say, has achieved enormous success, and so it's the next iteration, and digital technology is a huge piece of it. In this, not just to have more machines that go bing and have interesting apps and things, but it's about how you actually engineer through the complexity and also create the connectivity in a world where there is just so much information. In that last session, somebody put up a slide that says the total world knowledge doubles every 12 hours. Well, that certainly, is the experience in healthcare. And while the blockbuster, that's hard to say, blockbuster drugs and so on, that impact has tapered. And indeed, if you look at diagnostic imaging, there was this huge raft of new modalities, but there's not, nothing much else immediately on the horizon. The next level is about how we join the dots on all of this, and also how we do more to engineer out error. But we've got these twin movements of standardisation on the one hand, but individualisation on the other, and no one health professional or organisation can sort of sort that all out itself. So even how we think of hospitals, public or private, how we think of clinical practice, that's all going to have to fundamentally be redesigned. And we're right up against it now in a lot of the frictions and challenges that we hear and face in the system.
And a big part of that, of course, is thinking about the human resource requirements going forward 20 years, which you have to then plan for now and start to change. And you have to change training models and thinking about what sort of numbers you need of certain human resources going forward, which is a great challenge.
And if I could just comment on that, if you think about, I was talking about the healthcare systems we've used to and designed and been very successful are about the patient taking the initiative in one way or another, even if it's scooped up into an ambulance and presenting. And then we train our clinicians, they're magnificent, thank God they are, that you can just turn up, they don't know anything about you, haven't got a previous history, and can, mobilise, use their pattern brains, and they learn, look at a whole lot of things, get some tests, whatever, and if it's urgent, hopefully save your life, get a whole lot of things to you, or otherwise work you through a process to try and sort it out and work through it. And then you go out of their field of view, and you don't think about them again unless they're suddenly back in your field of view. And I know I'm oversimplifying, but it really is like that. And that's how medicine's taught. Medicine's taught about how to do that problem solving and how to have the case present and then how to work your way through. And that's also always going to be a key piece. But it's a very different thing to sort of do some epidemiology and understand population medicine and actually take a whole bunch of data and come down to the issue in a cohort and then a targeted intervention and then
Right.
you contact the patient. That's very different.
Yes, and how many orthopaedic surgeons are we going to need in 15 years' time? Because that's how long it takes to train them. And we have to get that right, otherwise we risk that underuse, overuse problem that you spoke about a lot. So
Just picking up on a couple of things you mentioned there. So when you're talking about advances in medicine and the technology challenge, one of David Mates' favourite quotes is, "There's plenty of money in health that's just wasted and badly spent." So actually figuring out how to be much more efficient and use the dollar once and not have it spread around the system is really, really important. The other thing is it's all about people, right? So actually having people capability to understand how to use that money, how to work in a system-wide manner, how to reduce waste is, I think, it gives much better yields than focus on the tech. I think when the tech implications hit, I think it'll be probably a decade away before they really ring in, but they'll be quite significant. But in the meantime, just wringing every last cent out of that health dollar through building capability is really critical.
yeah, so I agree with you completely. So the technical efficiency versus the allocative efficiency trade-off there, absolutely. So we're going to open up. We've got one question in the back.
Hi, I'm Robin Cruck, and really enjoyed both your presentations. Can I take you to the section about the community and the recipient of the health services actually understanding what the dots are as well? I mean, I think we talked yesterday in a number of sessions about the impact of the Mediscare campaign in the election, which I think is, a reasonably solid message about, we talk about technical efficiency, we talk about innovation, and we, talk about it in bit pieces, but at the end of the day, the community normally hears money going out of healthcare. I'd be really interested in both the New Zealand perspective, well as Mary's great knowledge in terms of the Australian perspective. How can we get them a more active part of that discussion, as opposed to responding to concerns about something being lost? And I've got great empathy for that position, but that's probably one of our greatest challenges in terms of progress, I would think. I'd be interested in your views.
So one of the interesting things I think about healthcare that never fails to surprise me is that people think that it's full of intractable problems and that you can't figure out how to make change happen. In Canterbury, there's 18,000 people that have been involved in a large-scale transformation program, and the interesting thing about that is all those people will use the health system at some point in their life, or their friends, relatives will, and by actually having a transformation program that makes a significant difference like Canterbury has, what you're also starting to do is get those 18,000 people talking about how things are changing in the community. So you're doing a couple of things. You are actually increasing the efficiency of the system, plus you're also spreading the word about how it's being much more efficient. When Canterbury started off this transformation program 2006, 2007, in the previous decade, it was pretty toxic, and the way that people learned what was going on in the health system was on the front page where clinicians would complain, and there were lots and lots of complaints, lots and lots of headlines. Now you get an interesting position where clinicians are coming out on the front page and complaining that the Ministry of Health isn't understanding what's going on in Canterbury, isn't supporting it, and isn't doing its job. So there's a way in which you can spread the idea around transformation in an effective way by having the people work in the system actually working for you.
Mary, did you want to comment on that?
Yes, look, I think how you make this accessible to the broader community as to what are the issues which they need to be exercised about, and encouraging governments to consider to get a good healthcare system for the future is a real challenge. And I agree with Roger. I think the first place is to the people who are in health to understand it, and certainly I think a lot of the reforms that have gone on over the last 5 or 6 years within the public hospital systems that have made the system more transparent, more understandable, and a funding model that actually connected the dollars directly to clinical care, and then just put that out there and just put it all up. So it's all out there. Anybody can go to the website of the health service, their local health service, and look it up. And my experience, and I was amazed how powerful it was. that changed the whole clinical conversation, and I think did more for clinical engagement. At the same time, it was hugely beneficial to governments. It's scary for governments to make those difficult resource decisions so transparent. But in the end, it actually also really helps them because you can then, when the system is transparent and the principles on which the allocation has happened, as well as the quantum of dollars, then the argument becomes about whether your assumptions and models are right. I love having deep arguments about are penalties attached to readmission rates an appropriate way of doing it. That's the real conversation, rather than we haven't got enough money, or they've got all the money, why haven't we got the money, or those kind, which when you've got an opaque funding model that's at the mercy of the political cycles, then you get the system, the only way you can deal with resourcing the system is to get your issue heard on the front page of the paper. So I think starting within the system, but I do also think we've got to get those conversations with the community to resource them to have the conversations about what we're talking about here, but they're experiencing it. I mean, if people come into the hospital system, and I've experienced this, it's great. You turn up in an ED and mostly will try and do something for you and help you navigate and get you through and all the rest. And what people really notice then, when they might need to then access some other kinds of care or need something else, they start to think, well, isn't there a system there to make that happen for me? And what we're talking about in designing that future system is trying to create that. So I think people sense the need for it now. Yeah.
Just to pick up on that conversation, I think it's very easy for people to get hung up on the money, and patients don't really care about money. They don't give a toss. And the numbers are so incomprehensible that they're meaningless anyway. So in Canterbury, for example, they spend $1.4 billion on healthcare. Most people can't get their head around the difference between $1 million and $1 billion, right? So if you counted, a number every second, you could get to $1 million in about 13 days. For $1 billion, it takes about 30 years. So the gap in people's comprehension to those numbers means that talking about funding buckets just becomes meaningless. In Canterbury, it's refocused around patient time. So the shorter the amount of time you're in the system, the better. And that has two different impacts. The most important one is that clinicians in the system resonate strongly with that, because once again, they're not trained to deal with money either. All they want to do is help people. So shorten the amount of time they're in hospital, that's a metric which actually has meaning for them. And for the public, shortening treatment times and treatment pathways is a great outcome. The less time you're in hospital, less time you're in the system is much better, right? So changing the way you communicate and the narrative is really, really critical, because you talk about money, it disengages people straight away.
Okay, sorry, down front.
See, if you'd sat closer, it would have been easier.
I know. Kia ora tātou, Glenn Barclay. I'm National Secretary of the Public Service Association in New Zealand. So my question's to you, Roger, and unfortunately there's a bit of a spiel beforehand, but our union is one that's totally committed to high involvement, high performing organisations. And we've got a number of our work sites where we've got initiatives underway about giving our members voice, where the union is heavily involved in not so much managing the direct engagement between that might take place between our members and either facilitators like yourself or directly with employers, but we help create the frame by which that conversation can take place and make it a safe place to work. And there's quite a lot of research around the contribution that unions can make in that environment. I'm just thinking about, we've got members at Canterbury, and a couple of things occurred to me while you were speaking. One is that you mentioned Air New Zealand, but I'd be interested to know what you learnt from them, because I know they've got a high involvement process underway with unions directly involved in a partnership arrangement. And also I was down at Canterbury DHB not that long ago talking with a group of delegates in mental health who were stressed out, deeply cynical about their management, all the kind of stuff that you can hear all over the place of a health system under stress. So two things that occurred to me. One is that it'd be good to know how you view working with unions and the collective voice, the contribution to the processes that you've outlined, but also the risks, which we know are there, and there are risks to the unions when we get involved with these processes as well. But we talk to that group of members who have we weren't talking about the process that you've outlined, but they were experiencing the DHB as a difficult place to work in and very stressful. So there's, there's a kind of disjuncture often between what we think is happening and what workers sometimes actually perceive as happening.
Yeah, so a bit of context around that situation, as I understand it, is that there is, politely, a challenging environment between the Ministry of Health and the Canterbury District Health Board at the moment, particularly around mental health funding, and that relates to increased demand in services post-earthquake, where for some reason the Ministry of Health believes there's been no uptake in demand for services, where the stats show completely the opposite. And one of the battles that David Mates continually runs, and the board run as well, is with the ministry, trying to convince them that the numbers actually do tell a story, and you need to give appropriate resources to match those numbers. So you're absolutely right about mental health. It's a huge problem in Canterbury right now. And I can understand why people will be stressed, because the whole population has got a cohort of people coming through with post-traumatic stress disorder from the earthquakes. And that is showing itself in a whole number of different ways and putting a tremendous stress on the system right now. So you're absolutely right. With regards to union engagement, I think it's absolutely critical that you engage people at the front line, whether they're union or non-union, because there's other people that make a difference, right? So one of the things that we did very early on was ask people, what can you do to make it better? Because a chief exec, whether it's public sector or private sector, can't do much, really. Right? So you set the tone and you allow permission and sponsorship for people at the front line to actually make things happen. And whether it's union or non-union doesn't make any difference, as long as you're engaging people and you make them feel like they can participate and have a say in the workforce. That's the most important thing. Because if you have disempowered people, you get really poor outcomes, and in health that is not a good place to be. The last point you made, Air New Zealand. So very early on in the process, we recognised that there were challenges that the organisation faces, and this happens in any organisation I deal with. People tend to think that the problems they face are unique and that no one's got the same problems that they've got. So Air New Zealand, for example, we brought in one of their health and safety experts that talked about this model they have, which is essentially, they described it as they have, the analogy is metal discs with a hole drilled in them and an axle going through the middle. And if you start rotating each disc, and each disc represents something like cabin crew morale, engineering checks, safety check and all this sort of stuff, they're all rotating independently. When by chance the holes all line up, that's when an accident happens. So I talked about that model, and that lady actually talked about everything that happens from the time you make an online booking to the time you get off the plane, and everything that goes on along the way in health and safety. And the interesting thing that we took out of that was, in the health system, basically, I think it was a 737 of people die every certain time period. I can't remember what it was at the time. The question we put to people at the time was, would you get on an Air New Zealand flight if you said to them, we're pretty sure you're going to make it, but sometime in the next 6 months, one of these planes is going to drop out of the sky? And everyone went, well, that's just a ridiculous statement to make. People die in health systems. And we said, well, why can't you make it? So you take in that model and learn from it and try and make zero needless harm and deaths. It was really confrontational with people. But Air New Zealand basically say, no one's going to die on our planes. And this is the systems we put in place all the way through. Does that answer most of the questions? Feel free to push back if there's more commentary. We've got time.
I might invite Mary to comment as well if there's any parallels with the New South Wales or Australian situation.
Look, I think what you're alluding to there is very important in that thing about how people who lead the system and you have to go to the design elements of the system see it, and is there a connect or a disconnect with the people that are actually on the front line, and I do think that then you transpose that into a government context where. Again, I think the New Zealand Deputy Prime Minister yesterday talked about traditional culture of public servants is very good at managing up, and indeed that's a core job of the public service. The public service serving a Westminster government is to do that. That's the core job. and in both in the New Zealand system and in the state health systems, we expect that people to be that senior public servant and do that, and at this very same time also put on the hat of being CEO of a major health system, which is no different to being CEO of Kaiser or Intermount, some of those ones that you had up there, Roger, or anywhere else, and actually run a large, complex organisation. So one, that's a huge, I'd say, from my experience, it's 80% running that system, 20% being the senior public servant, but at any time you have to go into that senior public servant mode, and they're quite different things. But it does, in situations of stress, lead to that managing up one and the Westminster role dominating. And as soon as you do that, you lose the system. Here in New South Wales, after sort of a lot of pressures, some of which went to the Commonwealth state funding arrangements, there was a major inquiry into the state of the health service in New South Wales, the Garling Review. I don't know if you've heard of it, and a very thorough review, big thick reports and so on. But interestingly, the fundamental thing that Justice Garling found was at the heart of things that needed to be fixed was the fundamental disconnect that had occurred because of those stressors between the clinical community and the managerial community. And I personally used to call it, de-Kafkaesquing the public system, because I once said, trying to run a public hospital is, a Kafkaesque experience. And, I noticed somebody else said that yesterday, go and read the trial to try and, cope with navigating government business. And I thought, I had the same analogy. And so a lot of, in New South Wales, a lot of the reform focus, chastened by that finding, was about how to do that. And there's lots of ways you need to measure it. You need to have KPIs and measure and hold accountable. You need to have that porosity of communication. You need to create a culture. And when you say, what does innovation mean? I think it means giving people permission and frameworks and tools in which they can actually change the delivery. And you have to constantly, and education and support within the system. And then you get success, then you mustn't fall in love with that success, because then you start also to sort of, disconnect. So it does require a lot of discipline in an environment which is very easy to, especially when the going gets tough, to default to that, upward-looking government support role, which is a key piece of the role. In some jurisdictions with public hospitals, say both Hong Kong and Singapore, they actually separate out those roles, interestingly.
Yeah, well, if we get time, I might get to that point, actually. I think there was one at the front here, and then over to Christine.
Thank you very much. My name's Amy McLennan. I'm from the Australian Department of Prime Minister and Cabinet. And I have to apologise in advance. You've got me thinking about all sorts of interesting things, and this is a terribly formulated question, so please bear with me. It's kind of, Mary, you were talking about joining the dots, and Roger, you're talking a lot about user experience. And one of the topics I'm most interested in is this third challenge you were talking about, where we need to start joining the dots and kind of chronic disease and long-term health outcomes. And I've never heard it described as a disruptor before. I've thought it more of a kind of slow creeping kind of phenomenon. But when I think about people's experience in the world and also what we can learn from the world around us, a lot of the things that kind of play into determining chronic disease don't happen in the health sphere. So everything from advertising, we can learn from marketing companies that mass consumption is not individual choice, it's socially patterned for all sorts of reasons. Fair trade policies and trade policies in general can affect health, urban design, economic inequality, social cohesion, air quality, stress, education, discrimination, all sorts of things can kind of disrupt health and contribute to chronic disease and these kind of health outcomes. And I know there's been some suggestions of things like health in all policies, or kind of much more radical changes of thinking about this kind of third challenge of chronic disease. And I was wondering, what does it take, or how much does it take to really start trying something completely different, like thinking in that way and thinking outside of this kind of health sphere?
I think that's a great question, and one that I was formulating myself, and that is, I think, one of the truly disruptive perspectives in health is for a health system to be humble about what it can't achieve and what what contributes to health that isn't within the health sector? So it's a wonderful question.
Do you want me to have a go?
Please. Yeah.
Look, everything you say is absolutely right, and as part of that third group of things I taught, the health system of the 21st century, when we look back, and I won't be here, but but look back and say, well, that's how we evolved, we'll have found some answers to some of these things and look very different, and we do need to be humble about that. But the elements of that solution are starting to emerge and be experimented with, and I think one of the biggest things is this use of population approaches, because, of course, long before acute hospital systems developed, public policy in health was around public health, starting with, the water supply, the whole science of epidemiology started with, the sewerage and the water supply in London and the pump that was killing everybody. And so huge health gains have come from environmental and engineering solutions. And in fact, healthcare as a responsibility of government was about that. It was about disease control, killing rats in the rocks to stop bubonic plague circulating. It was about that sort of stuff. And in fact, it wasn't really till after the First World War that hospitals evolved into being, the temple of, healthcare systems. And you have to remember that, so where that in Australia, that manifested in that organisations that were NGOs, hospitals were for the poor, so they didn't die on the street. But then after the First World War, NGOs that had created these institutions started to become something the middle classes wanted, because they started to have technology in them, because you had to put the technology somewhere, because if you were middle class, the technology came to you in the doctor's black bag. And I always tell people, my mother had her tonsils out in Croydon Park on the dining room table in the 1930s, just to, so you get your head around that. And then what happened in this state, and I don't know the history in each other state, but in 1929, the state government finally said, we're putting so much money into you NGOs, we're going to have to sort of take you over and have a bit more discipline. And hence you got the first Public Hospitals Act 1929, and hospital systems starting to emerge. We're actually going right back now to saying, and then it became this beast consumed all the health dollars, and people saying, what about prevention? What about public health? What about social determinants of health? If we could spend money here, we wouldn't have to spend money there. Was seen over here and disadvantaged, and and the people were different, and the considerations different. What's happening, both in my own experience here in Australia, but also globally, is all those disciplines are now being embraced and starting to be understood in terms of trying to design health systems. And I think that's very, very interesting. We've got a long way to go. But I do think trying to marshal some of those things into the equation. And the other thing that seems to be happening is also those conversations used to be about, well, you've got the immediately distressed and ill person in front of you, you've got to do something for that person. And then you've got a separate set of considerations about how you might get the benefit of other investments well down the track. Now the sorts of models people are starting to develop actually bring those things into play at the front end, so that in managing chronic disease, for instance, getting somebody, diet and exercise, looking at their social circumstances that might prevent that, and those things are starting to come into the treatment mix, but out of a different discipline of public health. It's so I think that's where some of the future will where the expertise to help us develop that future models will come from.
So from my perspective, the work at Canterbury started from, it's a process I follow, essentially linking foresight to strategy to innovation. So a lot of organisations do innovation in independence, so you have the herding cats problem. They don't link it to a strategic capability, which should be informed by where the world's going long term. So the work at the DHB started out, where's the world going in 20 years' time? What does that mean for health? What does it mean for the DHB? What does it mean for innovation? Working through that process. So you're not looking at what's happening in health, you're looking at the bigger picture. That forces you to then start thinking about complexity and complex systems. So, some of the things that Mary talked about, sanitary conditions, environmental conditions, all start to come into play. And because it's a complex adaptive system you're trying to play with, there is never any one answer that's going to remain static. It's always going to be moving. So one of the things that we have really pushed in Canterbury is understanding complex systems, because people naturally have this desire to want to anchor their thinking in one place, right? If we just stop the whole system and do these 5 things, we're in a much better place. But in the meantime, everything's moving along all the time in different directions that you can't anticipate. So complexity theory is really useful to understand, and I'd encourage you to look at Dave Snowden's work, the Carnarvon framework. CYNEFIN is a good place to start to get your head around that.
And Roger, within the New Zealand experience, do you think there's true cross-sectoral integration around the notion of health, education, the criminal justice system, or do you think it's still a somewhat siloed approach?
I couldn't give you any informed insight about that. In my experience working in a whole range of industries, there is always a real lack of cross-sector insight, whether you're in public sector, private sector, infrastructure, telecoms, financial services, and that's because organisations are naturally set up to run the engine room.
Yeah.
So focus on KPIs, bring the revenue in, just keep on going. Corporate antibodies aren't really tolerated in public-private sector, and so that peripheral edge scanning concept is not well used in many organisations globally, let alone in health.
Okay. Professor Giles?
Thank you, Adam. And actually my question was going to be in the same space, and in some respects it's been answered, but just to further the conversation a bit around that same topic, Mary, thanks very much for the tour de force of structural and economic reform in health and hospital care. And I think by any measures and even the most disenchanted people would think that that is a terrific success story. And you mentioned some of the drivers of success there. But if we take the primary healthcare space, and in particular the problem of chronic health and how we might respond to that, and we look to the recent past and even the last 10 years, we see a number of false starts in that space. And I'm curious about whether part of that problem is because we've tried to transfer those drivers into the primary healthcare space, and perhaps we are not identifying the correct drivers, or in fact those drivers may not be the right may not provide the right levers for us to get the right solutions in the primary healthcare space. And so really that's by way of observation. And I know there's some current initiatives in this space, and you might be familiar with them to the extent that you're able to talk to us about what you think some of the underpinnings of the current initiatives are that will lead to success, even if not broad success in the way that the hospital healthcare part of the system has been successful in bringing about change.
Do you want to well, look, I think we must remember that the reforms that we were able to undertake with the National Health Reform Agreement as an impetus and ABF as a very useful tool in the public hospital space. And remembering one of the most useful things that did was align Commonwealth and state incentives and start to work against the sort of dysfunctional cost shift motivations between the two levels of government. That didn't just, we didn't just magically plug that in. If you look at the gestation of ABF, Victoria introduced it in the early 90s in particular circumstances, and maybe South Australia did a bit, but others, and certainly New South Wales, did not go that route for a very long time. The history of having a robust set of Australian DRGs, which are now probably the best developed ones in the world and used by other countries. The Commonwealth started off with some $5 million it put in one of the, I think, the second round of Medicare agreements in the 80s, and sort of invested and stimulated and got developed the Australian DRG system, so that by the time we came to this series of reforms, we already had some ready-made things that were there a history of having tried them, used them, false starts, a highly well-developed set of databases and knowing how to, we all knew how to cost and to count, we just weren't using it to pay. And that represents, that would have been mid-80s that the Commonwealth started putting that money in. So that's a lot, and early 90s that Victoria actually started to use it. So it's off the back of all of that we brought all of that and said, now let's have another go at it and see if we've got enough in place. And I think it's worked. It's certainly been very powerful. Both Queensland and New South Wales have used it to really move things along. So I think primary healthcare, we have a similar journey. So we had the National Health Reform Commission say you need to have some, we recognise primary healthcare is largely privately delivered, it's by a whole bunch of different players. It hasn't got a systemic organisation. It's a whole lot of little small activities for the most part. And therefore, how do we create some sort of structure around that? So we'd had Minister Wooldridge had introduced divisions of general practice to try and support general GPs, but he did that when did he do that? In the 90s. And then everybody said, oh, that's a foreign model, we're not the NHS or whatever, and but in fact, or we're not New Zealand, I think it took as much from New Zealand. We've got different models, but actually there were enough there that got some traction and some benefits. So then the Commission recommended Medicare locals, then that became part of it, and then that almost died completely, and then there was enough support in that election that Abbott put it back into the agenda and said we'll do it, but we'll do it better, and we've now got primary healthcare networks. So there's always lots of slips, and now that we're trying all these integrated care models, people say, oh yeah, we did that, coordinated care trials, but that was all probably part of how you do it. Well, that's a long answer, but you do have to realise these things are never just a quick fix.
Well, it brings me to the second point I raised after Roger's talk, which was risk, which was a theme of your talk. And I think risk is a fascinating thing from a disruptive policy point of view. I always point to the Netherlands example of a system where arguably they had one of the best healthcare systems in the world, and actually not only tinkered with it, but fundamentally changed it to try and improve it, and may have gone backwards, it's too early to say, but the fact that they had that appetite for risk to change it to try and make it better, I think speaks volumes. And I think New Zealand is often viewed as having a similar appetite for risk. We all talk about risk being achievable and doable at a micro policy level, but as you go through the meso to the macro, what is it that gives governments a higher appetite for risk?
This is actually, I was going to make this comment. What really bugs the hell out of me about the whole transformation program at Canterbury is that the design lab has attracted visitors from all around the country and literally all around the world. So a couple of years ago, the Queensland Premier, I think virtually chartered a 737, filled it with public servants, flew them across the design lab to show them what was going on, what was possible. Now, my standing joke with my counterparts at DHB is that by the entrance to the design lab, there should be a list of all the organisations who have come through the lab, which would be, massive, literally. Every week somebody comes through. Then you have a slightly smaller list of all the organisations who have come back and asked more questions. Then you have the very, very small list of those who have actually done something, right? So my request to you is stop talking and start doing. So Chris Vienne made the same point earlier, right? There's a real execution gap and a lack of appetite for risk. Some of the stuff is very easy to do. You go across to Canterbury, you can learn it firsthand. It's a 3-hour plane ride away if you're over the side of the pond. It's stuff that is very scalable, it's very practical. Even in New Zealand, people don't pick it up. It just bugs me. It's taxpayer money that's going to waste because you're not taking those same examples that's been proven now after 10 years with data and scaling it. Right? Start doing it, please, somebody.
Mary, did you want to?
Well, I think it goes to that we have to recognise that when these things have been tried and they didn't work, it's not a failure. my daughters were at school and they were in the junior school, and there was a Scot who was the head of the junior school, this very strong Scottish accent. She used to always say there's no such thing as mistakes, they're only experiments. and so all those things were coordinated care trials are an experiment. And then you draw on them, and then you also look at models in other places, recognising you've got to adapt them into your own space, and you have a go, but you do need to have the disciplines of feedback loops and a willingness then to adapt and to adapt as you go, and to recognise that the implementation will be iterative on those feedback loops. That's not a model that traditionally in government's been very comfortable. It's usually the big policy think piece, the big paper, a lot of argy-bargy, and you all agree, okay, let's go, Marines, let's go, and then you do it, and then you throw all those switches, and and the poor people are just have to try and make some sense of it. And then if it doesn't come off, you say, oh well, that didn't work, that was a waste of time. And as everything we've heard, we have to design government systems, a process where you can recognise that this is part of the process, and also what are the tools. So you don't just write it off, you've got to have the feedback loops rather than just go on to the next new fad. We did, this fad last time, we're going, next time it's now social impact investing, or it's nudging, or it's whether. These are all useful tools that can be applied to achieve some things, but they're just part of the tool base to say, can we use those and look at examples in other places and maybe bring them to bear on our space? Whereas I do find you tend to go, it's the next new big thing, and then sort of unquestioningly, so you've got to get religion, you've got to have the faith and go in and do it, rather than that practical, well, let's see how that works. What can we learn about it? How can we avoid some of the risks, learn mistakes from others? Let's give it a good old go and try to make it work. And look, if you're halfway there, and if it makes sense to people at the front line, you've got a very, very good chance that they're the ones that will turn it into something that'll work. So they're crucial. I once did a planning exercise when teaching people about planning, and it was one of those games, and they put you into two groups, and one were the implementers and one were the planners, and they made you sit in different rooms, and they gave the planners the problem, and it was a competition, and the implementers had to sit around waiting, for the planners to come up and give them the plan, and you had various teams doing this. And of course the people who won were when everybody got jack of that, and the two rooms got together against the rules and started to actually do it together, and to work out how to do it. And again, I think the nature of government makes it hard to have that porous free flow. I mean, even just probity considerations and all this kind of thing, you've got to always be thinking, can I have a cup of coffee from that person? Are they going to be tendering for work, or whatever, even as a sort of small service NGO. So you've got all of that there. And so one of my reflections on health is that certainly out of the state systems, one of the things is we've had the benefit that inside the tent we've actually had a very diverse set of players and stakeholders who are not really government. And so we've de facto been able to get some of that and some of that feedback loop, which to the extent we've got things to work, it's probably because of that.
So fascinating. I was a Harkness Fellow, luckily enough, which is a program where a dozen or so health policy experts from the world come together in the United States. And interesting, one of the first realisations you have in that group is you look at each other's systems and they're all in a different cycle of innovation or disruption or change. And the cynical perspective there is, well, we're all just chasing our own tails or chasing each other or something. But actually, what's happening is that we're all in our own learning system cycle, which can happen both domestically and on an international level. So on that, we're going to, on behalf of the Australian New Zealand School of Government, I'd like to thank you both very much for participating in this session. It's been fascinating, and I invite the audience to also. Thank you.